the last but not the least presentation, and I know that everybody tired right now at this moment in the evening, but I will try to explain simply what is the cellular therapy for immune modulation. So, as you can see in the literature, that cellular therapy also is called cell therapy and cytotherapy. And in recent years, there have been more solid evidence that cellular and humoral components of the immune system have a positive effect to the regeneration of damaged tissues, including limbs, skeletal muscle, heart, and nervous system. And among these many types of cellular therapy, one of the important one of the most important is mesenchymal stem cells or bone marrow derived mesenchymal stromal cells therapy. So what are these mesenchymal stromal cells and why are they so important? So they are multipotent cells found in several adult tissues, and in vitro experiments demonstrated that clonal human MSCs are able to differentiate in various lineages, including osteoblasts, chondrocytes, and adipocytes. And studies also have indicated that MSCs have capability to differentiate into muscle, neural precursors, cardiomyocytes, and possibly other cell types. So MSCs have been shown to provide cytokine and growth factor support for expansion of hematopoietic and embryonic stem cells. And these unique capabilities meant that they can be used for a wide range of treatment, including immune modulatory therapy, bone and cartilage regeneration, and neurological disorders. So first mentioning about these cells was in 1966, and it was mentioned by the Friedenstein et al. And they announced these cells as osteogenetic stem cells. What they have done at that time, they isolated and cultured these cells, and they found that these cells could form ectopic bone. So they called it osteogenetic stem cells. In 1991, Kaplan et al. Called these cells mesenchymal stem cells. And they found that these cells are similar to hematopoietic stem cells, and that they are capable of forming bone, cartilage, and other mesenchymal tissues. And from that time, there were a lot of different studies in which researchers were using different methods of isolation of these cells and expansion of these cells, and different approaches to characterize the cells. So, International Society for Cellular Therapy in 2006 defined minimal criteria for these cells. So these cells are defined by low immunogenic phenotype, and they have to have a specific surface antigen expression. They have fibroblast-like morphology, and they can adhere to plastic dish. Between the main functions, there are differentiation into various mesenchymal cell types, as I mentioned, the osteoblast, adipocytes, and chondroblast. These MSC cells have immunomodulatory potential, and also they support tissue regeneration. Mesenchymal stem cells have been used experimentally for treating inflammatory disorders, and partly due to their immunosuppressive properties. And one of the first studies in this field was DSS-induced murine colitis in the mouse. And researchers showed that systemically infused MSCs could effectively weaken colitis. And in this study, infusion of MSCs gave preventive and rapid recovery effect with long-term immunosuppressive action in mice with repeated chronic colitis. So what about the immunomodulation and how these mesenchymal cells act? And you know that they have function in many ways, and there is no one way. There are many ways. So via multiple possible pathways, MSC suppress proliferation of both T helper and T regulatory and T cytotoxic cells. Also, with this suppression, they have anti-inflammatory environment. They are causing anti-inflammatory environment. They are reducing neutrophils migration to the tissue. Also, they inhibiting maturation of dendritic cells, and they are giving the impulse monocytes to become macrophages. Also, they are inhibiting NK cells proliferation and also the same cytotoxicity. And also they are inhibiting B cells proliferation and plasma cells proliferation, and production of antibodies is reduced. So there are a lot of many different pathways in which they act. So because of these different action and because of this immunomodulatory properties, MSC could be used for clinical application. And these cells are suitable for cell therapy because they are cryopreservable. This allogenic application is safe, and it is like drug cellular ATMP. Different mechanisms are used for different treatment options, like differentiation into various mesenchymal cell types are used for bone and cartilage reconstruction. Support of regeneration of damaged tissues is used for ischemic syndromes like myocardial revascularization, limb ischemia, diabetic foot. And immunomodulation is used like therapy of autoimmune diseases, prevention of kidney graft rejection, and promotion of engraftment after bone marrow transplantation. And if you would search in the clinical trials Gov database, there are 831 clinical trials registered of mesenchymal stem cells for a variety of therapeutic applications. So we have a lot of clinical trials going on with these cells, so they are really popular right now. One of the most known characteristics, as I said, is their immunosuppressive properties, and these findings provided background for clinical applications of MSCs in the treatment of, especially in graft versus host disease. And because this graft versus host disease is an important cause of treatment-related mortality and morbidity following stem cell transplantation. And as you can see, we could have really bad cases of GVHD of liver, gut, and skin, and we have really big survival differences in the patients with GVHD and without it. Nowadays, allogenic stem cell transplantation is successful therapy, and it's used for patients suffering from hematological diseases, as well as immunodeficiencies and metabolic disorders. And in many cases, this treatment option is the only one option for these patients. And GVHD remains a significant cause of transplant-related mortality and morbidity. And if we have GVHD, first-line treatment consists of extended immunosuppressive therapy with corticosteroids. But still we have steroid refractory acute GVHD. And this complication has a high mortality rate, as well reduces life expectancy, performance, and quality of life if patients develop chronic GVHD. So this is not the easy way to treat these patients, as you can see. So For this cause, mesenchymal stem cells have been applied, and I'm not gonna explain the difficult mechanisms. I just want to say that they works in tissue regeneration, differentiation of antigen-presenting cells to tolerance-inducing phenotypes, inhibition of T and natural killer cells, and induction of regulatory T cells. As I said, there is a lot of different mechanisms. So. The first case of severe steroid-resistant GVHD successfully treated with MSCs was described in 2004. In this trial, they transplanted haploidentical mesenchymal stem cells in a patient with severe treatment-resistant grade 4 acute graft-versus-host disease, and it was 9-year-old boy, and he had the gut and liver GVHD. And clinical response was striking. And the patient was well after 1 year. Then they postulated that mesenchymal stem cells have a potent immunosuppressive effect in vivo also. And following this observation, they started new trial with 55 patients, and the same with steroid refractory acute graft-versus-host disease. And in this trial were involved 5 European centers. After this trial, in the results, we can see that 30 patients had complete response and 9 showed improvement. No patients had side effects during or immediately after infusion of mesenchymal stem cells. And complete responders had lower transplantation-related mortality after 1 year after infusion that did the patient with partial or no response. So as you can see, the before, this is skin GVHD, and it's before and after. Following these encouraging results, several non-randomized studies were published describing the effects of MSC infusion in steroid-refractory acute GVHD. So in clinical studies, you can find prospective cohort studies with adults and children, acute and chronic GVHD, first or second line treatment, different MSC sources, and or culture methods. And there was a need for randomized phase 3 trial. And here we go with the HOVON 113 MSC trial. So this is prospective randomized double-blind multi-center phase 3 trial. And principal investigator is Professor Fibé from Leiden University Medical Center in Netherlands. This trial started at 2004, and the aim was to get 150 patients, and duration was 3 years. Currently, it is open in 5 trial centers, and as you can see, there is a lot of participating countries. So. What was the study objectives? First of all, to assess whether mesenchymal stem cells treatment of steroid-refractory acute GVHD is effective, and to assess is it safe. Of course, additional objectives were to assess the overall and progression-free survival, to assess the time required for continued pharmacological immune suppression, incidence of severe infections, incidence and severity of chronic GVHD in this group, and many other objective aims. So the treatment schedule, as I said, had the patients who have steroid refractory acute GVHD, and in the grade 2 and 2 to 4 with organ involvement. And there are 2 arms. In arm A, we have patients with mycophenolate mofetil and placebo in day 1 and day 8. And in arm B, we have patients with mycophenolate mofetil and mesenchymal stem cells infusion on day 1 and day 8. They get 2 times 10-fold 6 per kilogram body weight mesenchymal stem cells. Evaluation is done at day 29, and of protocol treatment, the patient are followed for 2 years, and still they are following for 10 years after randomization. Inclusion criteria are all patients that underwent an allogeneic stem cell transplantation for malignant or non-malignant hematological disorder and developed grade 2 to 4 graft versus host disease with gut and or liver involvement, and have grade 4 graft versus host disease, mixed response or progressive disease after 5 days, or stable grade 2 to 3 disease after 7 days treatment with 2 milligrams per kilogram corticosteroids and calcineurin inhibitor. Patients of any age can be included, and they should have Karnofsky score more than 20. Exclusion criteria are actually really big, and that's why it's not so easy to include a lot of patients from different centers. So for these patients, systemic treatment for acute GVHD other than steroids and calcineurin inhibitor is an exclusion criteria. The same as consecutive treatment with 2 milligrams per kilogram prednisolone or steroid equivalent more than 10 days directly prior to inclusion, previous treatment with ATMP, poor performance, not expected to survive 14 days, known and controlled toxicity for the MSO, and history of solid malignancy, pregnancy, and if psychological, familial, sociological, and or geographical condition potentially hampering compliance, and use of prophylactic mycophenolate mofetil or Mufortic less than 6 days prior to development of acute GVHD. And because in the many centers prophylactic mycophenolate mofetil is as normal as a routine treatment, that's why there are no as many patients as researchers would like to have. So clinical evaluation is taken at this, as you can see, and hematology and chemistry samples are taken. There are acute GVHD evaluation form, and if we have involved tissues, biopsy is taken, and quality of life questionnaires are given also. So there is a scoring form of GVHD, and every patient is standardized by the stage, evaluated by the skin, gastrointestinal, liver GVHD. What are the potential risks associated with this mesenchymal stem cell treatment? Of course, it's infusion reaction, and because of preservative DMSO toxicity, microbial contamination. It could be post-transfusion virus and or prion infection, ectopic tissue formation, tumorigenicity, immunosuppression resulting in increased rate of infection, relapse of the original malignancy, and long-term effects as yet unknown. And in this study, emergency deblinding could be done only when breaking the blind is necessary to manage serious adverse events, and only by study team. So for my presentation end, I would like to say that we have a lot of different countries participating in this trial, and I would like to mention that in this trial they plan to do the mesenchymal cell production in 5 different centers according to standardized protocols, but only 2 centers got the approval for the production, and it is Leiden Hospital and Leipzig Hospital, and it's because mesenchymal stem cell production is very hard and requires a lot of attention and precise work, so it's not easy to do that. But hopefully this good practice will come to Kaunas as an example with our Leipzig colleagues' help. So thank you.